This meeting is now being recorded.
Okay, thank you. Here is the agenda for today's call. The agenda includes a discussion of the scope of neonatal abstinence syndrome, an overview of the OPQC NAS project. We'll talk about understanding addiction as a chronic illness and a description of next steps and some helpful resources. Next slide, please. The objectives are listed here for your review. Note that the faculty will be talking with you about helpful strategies and role behaviors of community hospital staff that support a compassionate approach to NAS treatment. There will be time for open discussion during the call. Next slide, please. At this time, I'd like to introduce our faculty. Dr. Maura Crowley is a neonatologist at Rainbow Babies and Children's Hospital in Cleveland, Ohio. She is co-director of the neonatal ECMO program and assistant professor in pediatrics at the University Hospital's Case Medical Center. She is also an OPQC neonatal faculty member. Dr. Scott Wexelblatt is a board-certified pediatrician. He works with Cincinnati Children's Hospital and Medical Center in Cincinnati, Ohio, where he is the medical director of regional newborn services. He is assistant professor in pediatrics at the University of Cincinnati, and he too is a member of the OPQC neonatal faculty. Dr. Michelle Walsh is a neonatologist and the division chief of neonatology at Rainbow Babies and Children's Hospital, Case Medical Center in Cleveland, Ohio. She is the neonatal clinical lead for the OPQC neonatal projects. Now I'd like to turn the webinar over to Drs. Crowley and Wexelblatt. Maura, Scott?
Thanks. I'm going to do the first portion, and then Moira is going to be doing the second half. So our first thing that we want to know is open up a poll for everybody, and we want to know who's your go-to person when you have a baby that is identified with neonatal abstinence syndrome. So at this time, if you could go ahead and have one person, or if there's multiple in the room, go ahead and start clicking on who you would choose as your go-to person. We're up to 40% right now. And right now we're at 75% of the people have put in a vote, so we'll close it in 10 more seconds. Great. Well, I think we can close it now and display the results. So actually, this is great because we have a nice widespread distribution. 33% are going ahead and calling social work. 37% are specially trained physician. And 37% also selected, we really don't want having one specific person to help us out. So great responses, widespread, and exactly what we've seen in our other webinars. Next slide. So first part we're going to talk about is the background of how we sort of got into this situation, and then I'm also going to then talk about what we have found in Ohio, and then Moira is going to talk more about addiction as a chronic disease. So in 1995, there was a study that showed that cancer patients' pain was greatly undertreated. So the American Pain Association issued guidelines on how to on pain management. Then this got adopted by the U.S. Veterans Affairs Department. And then in the year 2000, Joint Commission said, you know what, this pain is important. We need to address this, and we're going to make pain as our fifth vital sign. A well-intended policy, but as we're going to show you, there may be some unintended consequences from this Joint Commission fifth vital sign. Next slide. So these next 5 slides we're going to show you is red areas on the map. These are all county related in Ohio. These are the percentage of patients with opiate addiction being treated in the region. So you can see our highest region at this time in the year 2001 was up in the northern part. And this is in 2001. So if we go to the next slides, you're going to see that this red area starts spreading pretty dramatically, a lot in the northern and then the southern river corridor, and starts centrally. And this is in 2005. Next slide is in 2007. You can see there's a lot more red areas, spreading more, and then keep on going. On to 2009, you can see this is almost a completely statewide problem. And then on the next slide, you can see in 2011, these are admissions for opiate-related addiction treatment needs. And almost every county in Ohio is seeing a significant increase, with Scioto County down in the river corridor has 70% of the admissions are opiate-related. This is another area, this article in 2012 showed, you can't really see the small numbers, but the red area, this is reporting heroin deaths in the, I can't pronounce the Cuyahoga County, but of that small number in the Cleveland area, there were 71 deaths during that year from heroin overdose. And then if you look at the other major cities on the right-hand side of the graph, each year there's been a significant increase, almost every quarter, half year, reporting on increase in deaths due to unintentional opiate overdoses. And actually the year 2009 in Ohio, unintentional overdose due to opiates surpassed motor vehicle accidents and homicides as a cause of death. This is an article from 2012 that was published in JAMA, and this looks at the rate of maternal opiate use. And there's been a 5-fold increase in maternal opiate use from the year 2000 to the year 2009. And the next slide is going to show that the rate of neonatal abstinence syndrome has followed with a 3-fold increase from the year 2000 to 2009. And these are from articles published in JAMA in 2012. The problem with neonatal abstinence syndrome, it's just not a clear-cut opiate withdrawal, because there's also lots of other polysubstance abuse that is happening with our infants that have neonatal abstinence syndrome. So this slide captures our data from our OCHA database, which I'll go into more detail shortly. But what we found is that 80% of these babies are being exposed to tobacco, 50% to marijuana, around 10% to cocaine, and 8% to alcohol. So it's not purely opiate withdrawal. There's other substances being involved that is clouding the picture. And the next slide is going to show you that our moms, they're not only smoking, 82% are exposing their infants to tobacco, but when we looked at cord data on infants that were being treated for neonatal abstinence syndrome, we looked at their nicotine byproduct level, and what we found is that the average U.S. smoker has 100 nanograms, but our moms that were smoking in the umbilical cords, the babies were being exposed to 135. With one, our maximum level was actually 270 nanograms. Not only are they being exposed to tobacco, but 10% of our infants are being exposed to SSRIs or benzodiazepines, which also cause different withdrawal syndromes and symptoms in our infants. So neonatal abstinence syndrome is not as clear-cut as we sometimes try to make it out to be. This side just shows that we have large variability by region in illegal substance use. Narcotic abuse is different in some regions. Central is different than northern and southern. So what are we going to do about this problem? So OPQC has taken on neonatal abstinence syndrome as its project for the next 18 months. Our aim is to, by increasing identification and by instituting compassionate withdrawal treatment for full-term infants born with neonatal abstinence syndrome, we will try to reduce the length of stay by 20% across the participating sites by June 30th of 2015. And this is our key driver diagram that we have set up to try to go ahead and tackle this problem. Our global aim, the top left-hand corner, that if you're not used to seeing key driver diagrams, shows that our goal is to reduce the number of moms and babies with narcotic exposure and to reduce the need for treatment of NAS. And our SMART aim is what we just told you, that our goal is also to reduce the length of stay by 20%. Our middle column shows how we think we can go about doing this, and our interventions are on the right on strategies that we have to go ahead and work on these to work on this project. Our next slide is going to show you it's almost the same, except this is designed more for our level 1 hospitals, more focusing on identifying these infants, going ahead and optimizing our non-pharmacologic bundle and scoring systems, which we're going to talk about on later webinars, and is a little more focused down than our level 2s and 3 sites, which have other issues with standardizing treatment and other problems. So what's the benefit of joining OPQC on tackling this project? Well, the best thing is that you get to learn from all of your colleagues. You're going to have access to experts in the field of addiction medicine. And if this is your first time doing quality improvement, this methodology is going to help you in all of your future projects on how to go ahead and tackle a problem. And the whole idea behind this collaboration is that we all teach and we all learn together. There's not a top-down mentality here. So the next section I want to talk about is give you some research that we have done over the past 2 years. Ohio Children's Hospital collaboration, OCHA, which we'll refer to, is a group of the 6 Ohio Children's Hospitals. We got a grant from the governor to try to identify what's the potentially best practice out there and try to identify different variation in treatment of infants with NAS and try to come up with a best practice and see how we could all learn together addressing the same problem instead of working on 6 individual silos. So we actually have a longitudinal cohort of term infants. So we're looking at infants greater than 37 weeks in this project for OPQC. Our OCHA project looked at infants down to 36 weeks. And so I'm going to give you some of that data that we came up with right now. So this data was run after looking at 660 infants, and we only are looking at infants that needed pharmacologic treatment for neonatal abstinence syndrome symptoms and signs. So if you needed to be admitted but never received methadone or morphine treatment, pharmacologic treatment, we didn't put you into this database. We currently are up to 800 neonates, unfortunately. It's a large number, but it's also great that we actually are getting a lot of data. So when we ran this report, we have 660 infants and moms. So the mom's average age was 27, with 92% being white, non-Hispanic. 84% of these moms are single, and 80% are on public insurance, with 10% having no insurance. 10% have private insurance. The good thing is that 89% of these moms are actually going in and having some prenatal care. Unfortunately, they're also having 85% of them are having complications with their pregnancies. 7% have STDs during their pregnancy. But one of the most surprising and alarming rates that we found is that 26% of these moms actually had hepatitis C. So something that we need to address with these infants that we identify with neonatal abstinence syndrome, going back and really getting a good detailed history or maybe some extra laboratory testing on the moms. This slide you already saw earlier. We found that our babies, this is looking at umbilical cord sampling, which is a test that gives us a global picture. It's sort of the same concept of meconium testing. It gives you a look back to around 20 weeks gestation, going towards the time of birth. And the metabolites accumulate in the Wharton's jellies the same way it does accumulate in the meconium. So you can get a broad picture of what this infant's been exposed to throughout its whole pregnancy. And what we found is, like we mentioned earlier, 80% were exposed to tobacco, 50% marijuana. And this is the same repeated slide that showed you that our moms were smoking more than the average adult smoker. So now getting down to the infants, our average symptoms occurred at 46 hours. This is important for hospitals to know that their opiate-exposed babies really need to be observed for a little bit longer. AAP guideline states 4 to 7 days. Our hospital does 72 hours for prescription pills, 96 hours for methadone and buprenorphine. But like I said, the AAP guideline says 4 to 7 days for opiate-exposed infants to be observed in the hospital, because we know that the signs and symptoms don't show up until 46 hours of the average. Our infants got treated for 18 days, and their average length of hospitalization was 22 days. Unfortunately, our average number of drugs to treat these babies is 1.5 drugs, meaning that 50% of them, meaning that we needed an adjuvant therapy, which we are all using phenobarbital in our cohort, our 6 hospitals. So a third of them are needing to add phenobarbital on top of their opiate. The other good thing that we found when we were doing this is that half of our units were using morphine to treat the infant as a first-line therapy, and the other half were using methadone. So after we collected this data, we came up with a potentially better protocol, which still has room to be worked on, and that's what we're doing, this collaboration. We all want to learn from each other and teach, and so we are not saying this is the way to do it. We just think this is a better way to do it, and having a protocol definitely does shorten your length of stay. So the most important thing to do is non-pharmacologic bundling. That's swaddling the infant, trying to keep them comfortable as possible. We want to initiate pharmacologic treatment when the NAS scores, these are Finnegan scores at the level 2s and 3s, are greater than 8 times 2 or greater than 12 times 1. We are telling sites that are treating infants to pick a drug, either pick morphine or pick methadone. We were able to show in our large cohort it doesn't matter which drug you choose. It's just picking one drug for that unit and staying on a set protocol with set parameters on when to wean. That was the driving factor. So morphine is not better than methadone. Methadone is not better than morphine. It's just saying we're only going to use this drug. We're going to follow this protocol. We increase the dosage if the scores go greater than or equal to 8. We stabilize the drug stabilize for 48 hours, and then we start weaning by 10%. And we observe the baby for 48 hours off pharmacologic treatment to make sure there's not a rebound. So this looks at consecutive patients treated on the bottom. And one of our pilot hospitals that didn't have a protocol said, you know what, we're going to go and adapt this OCHA protocol to see if it can help decrease our treatment days. And what they showed, it was a dramatic decrease. So they were averaging roughly 45-ish days, and now they're down to 18 days, getting back to where we were. So we know that adopting this protocol can have a significant impact. So the other areas that we're going to focus on future webinars is we're going to try to improve non-judgmental support, try to think of addiction as a trauma-informed compassionate care chronic disease. We're also going to try to work on improving consistency in scoring. There's different scoring tools out there. Our goal is for our level 1 sites is to train nurses to improve reliability in the scoring using the Lipsitz tool. This is an 11-item subjective measure of withdrawal symptoms, and this is going to be discussed in our next webinar. But we are also able to show by instituting a Finnegan scoring training program that our nurses were able to decrease the inter-user reliability, improve our inter-user reliability. So we know that our night nurses are scoring the same as our daytime nurses, and that nurse A is scoring the same way as nurse B. And then we're also going to be talking about our non-pharmacologic bundle. Questions that people say, is a NICU better, or is couplet single rooms important? We're going to talk about soothing techniques, also prenatal counseling of mothers, improving that, on explaining what the chance of withdrawal is going to be and how they can actually work on soothing the baby. And then also talk feedings for the non-pharmacologic bundle. Is mom's milk is fine if they're in a controlled treatment program with no other illicit substances. There's also looking to starting high caloric formula, 22 calorie instead of 20 calorie, and looking at low lactose formula over traditional formula. So next we want to take a pause here and address any questions that people are having on the background and what we found in our OCHA study, if there's questions on those aspects at this time. So there's multiple ways you can type it into the question box or raise your hand on the button for the webinar, and I think Beth will be able to identify those folks.
Absolutely. Raj, Jess, do we have any questions?
As of right now, no.
Okay. Okay, Dr. Wetzelblatt, I think you can continue. There are other opportunities for questions throughout the webinar. So if something comes to your mind, please feel free to type the question in the question box, and it will be addressed throughout the webinar. You can be assured of that. Okay.
And I'm going to turn it over to Moira now.
Okay.
Can you hear me?
Yes, we can.
Okay, great. So I am going to talk about understanding addiction as a chronic illness, and I do want to acknowledge that this content is actually from Krisanna Deppen, who is a family medicine, addiction medicine specialist, and she has provided this information for our level 2 and 3 hospitals, and unfortunately was unavailable to talk with us today. So I'm going to try and do her slides justice. So we wanted to start this part of the talk with taking another poll and asking you, to what extent is an individual personally responsible for their addiction problem? So we'll open up this poll for everybody just to see what we all think. About 2/3 are voted in. We'll keep it open for another 10 seconds or so. All right, so we have about 59% of us feel that these individuals are moderately responsible, and 40% feel that they are very responsible. And that's about what we expect to see. And part of the goals of the statewide collaborative is for the medical community that are involved in the care of these families to improve our care not only for the babies but also for the mothers, and become more compassionate and non-judgmental in our care. And hopefully this will promote a better long-term outcome for both baby and mother. So in an effort to understand addiction, we will discuss a lot of the common misconceptions about addiction. So next slide. So click again. So, addiction has been portrayed in the news in not the best fashion. So just keep clicking on. There's, a lot of headlines that are very sensational and can portray these mothers as criminals against their babies. Next slide. So a common myth is that if these moms really cared about their babies, they would just quit. Keep clicking. So it's important to understand that those who can quit often do. Addiction has multiple effects on the brain, and addiction is similar to other chronic medical illnesses. Next slide. So addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors that influence its development and manifestations. There is a neurobiology of addiction that includes the role of dopamine in the brain, and the neurobiology of addiction encompasses more than the neurochemistry of just reward. In the frontal cortex, we've known that there's altered impulse control, altered judgment, and the dysfunctional pursuit of rewards. Next slide. And addiction has been studied, and it's been shown that relapse rates are similar for drug addiction as other chronic illnesses. So drug addiction, about 60% will have relapses, and which is very similar to those with type 1 diabetes, hypertension, and asthma. So we should be looking at this as another disease that we have to watch and help these women through. Another common myth is that methadone or buprenorphine is just another addiction. So next, click again. So dependence is different than addiction. Methadone and buprenorphine are legal, safe, and they're monitored. And studies have shown that there's improved outcomes with women who are on methadone. Next slide. So dependence is different than addiction. So a physical dependence is tolerance and withdrawal can develop with appropriate use of prescription medications, so either pain medications or addiction treatments. And an addiction, in contrast, is characterized by behaviors that include one or more of the following. So impaired control over drug use, continued use despite it causing harm, and craving, so the 3 C's. Next slide. And opiate maintenance therapy, so specifically when we talk about methadone, so this began in 1967 by Dole and Niswander, and it's been shown to improve outcomes by decreased mortality, reduced illicit drug use, reduced seroconversion to HIV, decreased criminal activity, and increased socially productive activities. However, only 10 to 20% of patients who discontinue maintenance therapy are able to remain abstinent. And PET scans suggest that methadone maintenance at least partly normalizes cerebral glucose metabolism when compared to patients withdrawn from methadone in sustained remission. So, another common myth is maintenance therapy is helpful for mom, but it can't be good for baby. However, it's been shown that both methadone improves maternal outcomes, improves obstetrical outcomes, which all in turn improves neonatal outcomes. Next slide. So things that we see that improves in maternal health is there's decreased risk for mom to relapse. It improves her seeking prenatal care. There's a higher likelihood from abstinence from concomitant drug use. And we know that what Dr. Wexelblack had talked about is that we have a lot of these babies that are exposed to multiple substances. And untreated heroin use in pregnancy is linked to growth restriction, placental abruption, fetal demise, and preterm labor. So if these moms can get into maintenance therapy, hopefully we can reduce these adverse outcomes. And fetal improvements, so treatment has been shown to have higher birth weights in these infants, and as well as higher gestational ages. So both improving the long-term outcomes of these babies. Another common myth is these moms are so much work, it really isn't worth it. However, improving the care of these families is valuable to the infant care and development. Improving care is valuable to the substance-using family, and it can also be valuable to your staff and even you. So the benefits of improved care of infants and family, with the infants, so after delivery, long-term outcomes are improved with a safe, sober environment for these infants to grow up in, and it's also facilitated by early bonding with mom and baby. And the mother and families, recovery from addiction is life-changing, and recovery occurs at similar rates to treatment as many other chronic illnesses and medical diseases, which we've talked about. And the delivery of an infant affected by drug use could be a teachable moment. So we have multiple opportunities to affect both mom and baby with compassionate care. So the importance to medical providers is, providing substance-using families a different experience of the healthcare system may help facilitate better bonding and care for the infants. So both the mom and the baby can seek appropriate medical care. And in creating an environment where the moms are welcome can create a better environment for us to work in. And understanding addiction and learning skills to communicate effectively with this family could lessen the caregiver burnout and stress. So So how can we start to engage our mothers? So kind of a brief intro into motivational interviewing. So motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. So there are 5 components to motivational interviewing. So expressing empathy, develop discrepancy, support self-efficacy, roll with resistance, and eliciting change talk and commitment language. So some skills that we can use to engage our mothers. So in conclusion, addiction is a chronic and treatable disease. Opiate maintenance therapy with methadone or buprenorphine may play an important role in treatment of pregnant women struggling with addiction. Opiate maintenance therapy improves outcomes for both pregnant women and their infants, and by providing non-judgmental and compassionate care, it can be rewarding and beneficial for the patients as well as the providers. And I think at this time we'll open up for any questions.
Yes, remember that you can click on the raised hand icon and type in a question. We do have 2 questions. The first is from Margaret asking, will the PowerPoint be available following the webinar? Yes, it will. It will be posted on the OPQC website after the second of these webinars, which will be next Tuesday on the 17th. The next question is from Leslie. She says the spread data that was originally shown about the incidence of addiction across the state, was that just pregnant women or was that all people who are addicted?
No, that is all people who are addicted.
Okay. Okay, are there any other questions? Jess and Raj, are you seeing any that I am not?
Beth, we do have a hand raised by Ruth Dooley.
Okay, could you please read that?
She just has her hand raised. I don't see the question. Oh, there it is. What is a low lactose 22 cal formula that is available?
Good question.
So this is not readily available to buy. This is something that needs to be made by your nutritionist, if there is one. There's different ways to do it via concentrate or by powder. So this is something that usually only our level 3 facilities are able to do that have certified mixing formula rooms. I do know some sites switch to 22 cal Neosure, but that is not low lactose. It just gives more caloric input, as these infants during their withdrawal phase are at a much higher caloric need than the regular infants.
Yeah. And it's not something, we don't have these babies on the 22 calories throughout their hospitalization. It's mainly during the acute withdrawal phase. You know, while they may not be eating well, they still have higher caloric demands.
Okay, thank you. I think I see another hand. Jess, could you read that question, please?
It's by Carlene Higgins. What about Similac sensitive for NAS babies? So we, a majority of our people in our collaborative, I shouldn't say majority, but a lot use Similac sensitive, and that's our preferred formula to start using with NAS babies if breastfeeding is not appropriate. And we are actually able to concentrate that to 22 calorie as well, but we have dietary support to allow that to happen.
And in the Cincinnati region, we use that as a first line in our level 2s and only don't really have the capability to go to 22 calorie so in our level 2 facilities. So then that's when the decision is if they've lost more than 10% or have an increased output and not able to gain weight, then we'll start thinking about changing it. But any Gentlease is the next question. Same as Sim Sensitive, just different brands with low lactose formula is really what's been shown to help.
We have another question from Carrie Barnes. What are the guidelines for using mother's breast milk in women who are being treated for addiction?
So I can tell you what our guidelines are at our hospital, and as long as the mom is in a treatment program and her counselor agrees that it is beneficial for both mom and baby, then we do allow the mom to breastfeed. If she is not in a program or we know that she's using other substances, illicit substances, then we do not allow her to provide breast milk for her baby.
And that's the same thing we do in our region also.
Okay, that's great. That looks like all the questions we have. Thank you, Drs. Crowley and Wexelbrad. This was, and everyone who participated, this was a great reminder of the relationship between knowledge of medical treatment and compassionate approaches to care for optimal outcome of babies with NAS and their parents. Okay, the next slide, please. And next slide. Okay, we'd like to briefly review with you some next steps so that you can plan to continue this discussion with us as time goes by. The webinar will be repeated again on June 17th. That's next Tuesday at noon. There's still time to register, so please tell your colleagues if you enjoyed this today to call in and register. Our second webinar on this topic will be in the early fall. You'll be given an announcement about that very shortly. The topic will be identification of women who use narcotics, particularly approaches to screening and drug testing, legal issues, and the duty to report for healthcare professionals. The second webinar will also talk about the LipSIP scoring system for newborns and discuss when is it safe to discharge. The third webinar on this topic will be in the middle of fall in 2014, and the basic emphasis will be non-pharmacologic care, how to optimize non-pharmacological care of babies with NAS, and then who needs to be referred for treatment, how would mothers be identified and referred appropriately for treatment. Next slide, please. Here are some resources that we hope you find helpful. You will note that on the opqc.net website, there are a number of very helpful resources that are available on the publicly accessed sites. Those of you that have been part of OPQC projects before this will know that you can have access to SharePoint. You do have access to the members-only section of SharePoint, and there are additional resources there as well. My suspicion is that most of the people on the call have been part of an OPQC project in the past from my quick purview of those who have signed up today. If you have questions for any of us, please don't hesitate to send an email, and it will be sent out from the project management staff to the person who can best answer. And we do have a Twitter account, and every single day, almost, we have something that's very important and meaningful, I think, to our practice in maternity care of mothers and babies. This concludes our webinar for today. I want to thank you all for your time and interest. We look forward to continuing our discussion with you in future webinars. Thank you again. Bye.